My uh, presentation today, I will be discussing the prevalence and beliefs associated with vaccine hesitancy among Muslim Americans. Excuse me. As Dr. Staudinger mentioned earlier, this research was done as a part of my master's thesis at UT Tyler, and my thesis chair was Dr. William Sorensen. So here is a brief overview of what I'll be discussing today. And let's get started. So, vaccine hesitancy is the delay or the outright refusal of vaccines. I've already had a few rotations under my belt as a third-year medical student, and I can say I've definitely seen it as a problem for my attending physicians a few times. And so, there are many things that we are told are important or necessary to consider as future physicians, but I like to put these things in context. For one, there's herd immunity. You need about 70 to 80% of vaccine compliance for a population to achieve herd immunity. Moreover, there's a host of medical reasons. I'm talking immunocompromised people, babies, geriatrics. These groups rely on herd immunity to stay healthy. And with COVID-19, we saw that herd immunity really didn't reduce the incidence of new cases. In this situation, what we wanted to do with the vaccines was to prevent patients from dying from COVID-19 or preventing them from having any long-term sequela of their disease. And so this is one of my favorite graphs. I love showing it to everybody I see because it shows the cases of measles in the United States since World War II. It's on a logarithmic scale because the range of data is so wide. And so you can see prior to the deployment of the first measles vaccine, cases were close to the millions in number each year. And then once the measles vaccines were introduced, you see that the number of cases drastically declined. Around the late 90s was the start of the anti-vaccination movement. And you see the case numbers steadily going up. In 2019, there were over 1,000 cases. It was only in 2020, because of the COVID-19 pandemic, that case numbers started going down because of the quarantine policies. And now, as people leave quarantine, the number of measles cases is rising. And so in 2023, we had 48 cases. So we see that vaccine hesitancy has major negative consequences, and it's in our best interest to find ways to curb this pattern of behavior. For my study, I hypothesize that the prevalence of vaccine hesitancy among Muslim Americans will be similar to that of the wider US population. For example, I believe that Muslim Americans with fewer years of education will be more hesitant towards vaccines. Also, more religiously conservative Muslim Americans will be more hesitant, and people who are more trustful of public institutions and government institutions will be less vaccine hesitant. So, what are common vaccine hesitancy trends in the US? So, generally, people who strongly believed in adverse effects of vaccines, distrusted public institutions, felt a sense of helplessness, strongly supported bodily autonomy, and questioned vaccine efficacy were more hesitant or outright rejected them for their children. A really interesting study from Johnson et al. Found that 13% of college students were vaccine hesitant and were more likely to accept a vaccine if they thought there would be more intense physical suffering from an illness or previously had a family member or friend who contracted said illness in the past. According to Disbin, Held, and Carson, they compared medical students from multiple they compared healthcare, healthcare profession students across multiple um, fields of care. That included medical students, dental students, nursing students, and they gave them knowledge tests as well. And they found that nursing students were more vaccine hesitant despite scoring lower on the vaccine knowledge test. And 30% of dental professionals were either opposed to or hesitant to administer vaccines in their practice. They cited that cases of malpractice concerns or liability concerns as their most common reasons for hesitancy. So moving on, just wanted all and found that people who distrusted public institutions, were older in age, childless, and less educated were more likely to be vaccine hesitant. Another study found that 6.1% of parents were resistant against routine childhood vaccines, and 25.8% were resistant against the annual flu vaccine. Um, they found that parents of lower socioeconomic status, Hispanic heritage, and fewer years of education were more likely to be hesitant. These results actually contradict the results of those of Mesh and Schwerian, who found that people with more years of education and younger age were less likely to get vaccines. Unfortunately, contradictory findings are not uncommon in vaccine hesitancy research because of these inconsistencies. I believe that more research needs to be done on why people feel the way they feel about vaccines. And so now moving forward, most vaccine hesitancy studies among Muslims have been conducted in Muslim majority countries. I'm just in discussing prevalence rates among Muslims. I'm using percentages of vaccine support because this is how the data was reported in these studies. And as you can see, there is a wide variety in Middle Eastern countries, Malaysia, and in Asian countries. As you can see with Malaysia, there is less vaccine hesitancy, but we see a lot more vaccine hesitancy among Nigerian mothers. And then moving forward, COVID-19 gave us a breadth of new insight on vaccine hesitancy. And so two standout papers that I want to discuss are Lin et al. And Penn et al. These are systematic reviews on COVID-19 vaccine hesitancy. Penn et al. Looked at studies about parents, and Lin et al. Was on the general population. While they don't mention specific prevalence rates, they talked about similar themes. There was a general correlation between mistrust in public institutions and belief in conspiracy theories to vaccine hesitancy rates. And as for actual rates, the clearest information that we have among Muslims come from Muslim majority countries, and we have a wide variety of range on on how much of a population is accepting vaccines. And so, from the hesitancy studies in Muslim majority countries, there were multiple themes that resonated throughout each paper. Religious prohibitions, lack of parental experience, distrust within public institutions, political affiliations, and pork ingredients within vaccines strongly correlated with vaccine hesitancy. These are interesting findings, and they show that Muslims have unique health needs that need to be addressed. Unfortunately, there is no strong consensus on vaccine hesitancy trends in Muslim communities living in religiously heterogeneous societies like the US and the UK. This is concerning because the 2017 measles outbreak in the Minnesota Somali community showed that Muslim communities within America are at risk of succumbing to the consequences of vaccine hesitancy. Also, studies in religiously heterogeneous countries cast too wide of a net, and they often don't differentiate by religion. Moreover, there are many contradictory trends, which obscures our ability to track what can influence a person to reject vaccines. So, from the themes and considerations of my research, I created and implemented this project. This is a cross-sectional quantitative study in the form of a Qualtrics survey. My target sample size was 43. I based this off of a online sample size calculator, even though participants were convenience and snowball sampled. Selection of where the survey was marketed, like where it was basically advertised to, was a bit more deliberate because I believe that targeted recruitment could avoid any unwanted survey responses. And so this is my participant selection criteria. So because children can't make decisions about their own health, this survey was only for adults. Since there are immigrants to the US who view themselves as Muslim, it was necessary to set a limit on what the study defines as American. For my own personal experience as an immigrant, people need a few years to acclimate to a new country and kind of identify with it. And so I set a 5-year inclusion criterion. This was based on the US naturalization process, which says that you need to be a resident and be living in the US for at least 5 years to begin your naturalization process. And so the participants were recruited through word of mouth among social networks, Twitter, Instagram, and 10 Muslim oriented Facebook groups. And so participants were scored on 4 different belief categories. They were religiosity, vaccine hesitancy, trust in public trust in healthcare institutions and political ideology. The answer choices of certain questions were assigned a point value on a scale of 1 to 5, and the points were added up to calculate the score. Health belief scores were considered dependent variables. Generally, the higher the score, the stronger the belief. For example, a score of 5 for religiosity meant that the participant did not identify as a religious Muslim, but 25, which is the highest possible composite religiosity score, reflected intense religious devotion. The only exception to this rule was the political beliefs composite score, which analyzes the participant's political stance from extremely liberal to extremely conservative. For example, participants with a score of 10, the highest possible, identified as having very conservative political beliefs and social beliefs. And so this table shows a breakdown of the scores. And as you can see, each score is determined by the number of questions that make up the composite score. I did all my data analysis through SPSS. I got descriptive statistics. Sorry, excuse me. I got descriptive statistics for age, gender, race, the highest level of education completed, employment status, just to name a few. I also got descriptive statistics for Islamic sect affiliation, how the most common source of healthcare information that people received, and factors for vaccine hesitancy. The 4 belief scores were calculated for each participant. And so these scores were analyzed using independent samples t-tests to determine if there were associations with the demographic variables. I completed correlation tests between the scores and the linear variables of income and age. Finally, I did multiple regression analyses for my statistically significant values from my t-tests. I used 2 models for this. I will explain these a bit more further on as I discuss my results. And so here's the ethics of my study. And then next, let's go to the fun part, the results. Alrighty, so in total, 73 responses were received, with 89% meeting the inclusion criteria. This is 51% more responses than were desired. And from the pie chart, you can see that 45 people were female and 17 were male. One participant selected other as their gender identity. This person didn't specify their actual gender identity, and they had unusual response patterns. So I took out all of their survey responses for any further analyses. The average age of my sample was around 32, and the average income was $121,000, with the median being over 88,000. Looking at the racial and ethnic makeup of the sample, I was surprised to find that it was overwhelmingly Asian. To break down these numbers, there were 50 Asians, there were only 6 people who identified as white, and they made up the second largest group. So participants indicated their highest level of education attained at the time of completing the survey. 32 people, so that's over half of the sample, had at least a graduate or doctoral degree, and 24 people had a bachelor's degree, and they made up the second largest group. Next, moving forward, most people were employed or self-employed, and students made up the second largest group. Moving on, this shows marital status. 32 people were married. They made up the largest group. And then the second largest group was single, who were never married. And that was about like 25 people in my sample. Next, participants told me if they had at least one child under the age of 18 in their household, and 42 participants did not have any children. For religious sect, most participants, that was about 49 people in my sample, they identified as Sunni. And so participants were asked about where they received most of their health information. Most people, which is about 35 people, they received most of their healthcare information from a licensed healthcare professional. There were 5 people who used other sources. For all of them, they got health information from scholarly places like peer-reviewed journals or clinical resources like UpToDate. All but 2 participants in the sample excuse me, received at least 1 dose of the COVID-19 vaccine. First, participants reported on their most important factor in receiving a vaccine. This is shown on the bottom strip. The majority of people were more willing if a vaccine had no safety issues. The second largest group selected other as their most important factor. And of this group, 4 people were more willing to get a vaccine if it actually quote unquote prevented a disease. It, 3 were more willing if there was proven scientific evidence for a vaccine. 2 were more willing if a vaccine had no side effects. And another 2 were willing if they knew a vaccine could protect other people. And one person reported that there was not one factor, but many factors that affected their decision to get a vaccine. And another vaccine said that they would get any vaccine recommended by their healthcare provider. Next, I asked participants their main reason for avoiding a vaccine. So you see this in the top bar. There were 2 groups with 15 people each that made up the majority. The first group were less likely to get a vaccine if it had safety issues not listed in the survey. And the other group said that they were less likely, if a vaccine was less efficacious. So now moving on, let's look at the distribution of the calculated belief scores. I included the average and the standard deviation for them. Every category except vaccine had a normal distribution. And you can see that in this chart, which shows the distribution of the vaccine hesitancy belief scores. It had a bit of a negative skew. And so because of that, I transformed this data to make it easier to do my data analysis. And so as you can see, this is how the transformed vaccine hesitancy data is distributed. The equation for how I just transform that data is listed on the bottom. It shows a smoother, more normal histogram curve. Now moving forward, let's get to the independent samples t-test. And so this is bivariate analysis. And so I'm comparing the means of the belief scores. And if a variable wasn't already in 2 groups, I recoded it with an SPSS to make it 2 groups to be able to do the data analysis. And so the demographic variables on this list had statistically significant differences between their means. The group with the higher mean is listed next to its variable. For example, older participants had higher levels of trust in public institutions, while younger participants had more vaccine hesitancy. Since age and income were continuous variables, I wanted to analyze them using sort of like a correlation analysis without any data recoding. So I did that between those 2 variables and the 4 belief scores. The parametric Pearson correlation gave these statistically significant relationships that are listed on the screen. The arrows show the direction of the relationship. For example, as income increases, the level of religious belief increases. Next, I also wanted to do a Spearman correlation as well because it is a non-parametric tool. It's less sensitive to large outliers in either tails of the samples. So you lose the statistical significance between income level with the religiosity score and political score. That's why there are fewer positive or statistically significant Spearman correlations. Finally, I completed a multiple regression analyses on the significant variables from the t-test. This was the 2 models I was talking about earlier. So model 1 was just the significant variables. Model 2 was the significant variables plus the belief scores. Each model was adjusted, and so there were actually 4 models in place. For the multiple regression on trust scores, age was statistically significant for both model 1 and model 2 and had the largest slope value out of all the other significant variables. So basically, what does this tell us? Trust in public institutions increases as people get older. Lastly, I did a multiple regression analysis for vaccine hesitancy as I did for trust in public institutions. Model 1 showed that education was the strongest indicator, while model 2 showed that education level and trust were the strongest. Overall education had the largest slope value. Again, what does this tell us? Participants with more years of education were more likely to be vaccine hesitant. Vaccine hesitancy and trust were the only significant belief scores, while the political belief and religiosity scores really didn't make that much of an impact. So now that we have the results of the study, let's begin discussing their implications. So when comparing my findings to that of other studies, I realized that there were both affirmations and confirmations in trends. For age, I found that older participants were less likely to deny vaccinations. Here is a sample of the papers in my literature review that showed similar findings. Next, I found contradictory findings for education level. From the t-test, vaccine hesitancy decreases as people get more years of education. But the multiple regression found that vaccine hesitancy increased with more education. This sample of studies that went through they go through and they correlate with the findings of my t-test analyses. You can flip them when you consider the multiple regression analyses that I did. Next, moving forward, I found that people who are employed or self-employed were less likely to be vaccine hesitant. This sample of papers both supports and contradicts my findings. Next, I found that married participants were more vaccine hesitant. And these are the studies that both support and contradict this. Another finding that was really interesting to me was that Sunnis were less vaccine hesitant compared to those who are non-Sunni. In my entire literature review, I couldn't find hesitancy trends among Muslim sects. So this is the first study of its kind that I found. And I've continuously, I'm still looking throughout the data to see if anybody else has done a study like this and compared by sex. And really, this is the first one, to see a statistical difference in vaccine hesitancy trends between sex. And so currently I'm working on a follow-up study to retest this finding and to see if there are actual differences. But that was really the most interesting thing to me out of all of this. And so let's talk about the trend seen with the belief scores. Income had a positive relationship with participants' belief with their religious beliefs. Unfortunately, there is no recent data on the connection between high income and religion to compare to my study in the last religious landscape survey done by the Pew Research Center. That was in 2014, and it showed that people with higher incomes were less likely to attend religious services, have strongly associated beliefs in their faith, or even align themselves with a particular religion. So what I found does not correspond with wider trends on socioeconomic status and the extent of religious belief, but honestly, I can't really be sure. I also found that participants with stronger religious beliefs and practices tended to favor right-leaning political, economic, and social ideologies. This honestly wasn't really surprising to me. And then moving forward, I found that the political belief score had a relationship with age. I kind of expected this because older people tend to be more conservative than younger people. Also, I saw that younger people with people with higher incomes had more conservative political, economic, and social views. Again, this is also not really surprising to me. While adults tend to have stable political beliefs over time, those who do transition as they get older tend to go from more left-leaning to right-leaning. Lastly, let's discuss trends in the trust score. As people's trust in public institutions decreased, their vaccine hesitancy increased, which was supported in the correlation, multiple regression, and literature review. This connection makes sense because we can't expect someone to commit to an action if they fear it or have no compelling reason to engage with it. That being said, there is one association that contradicted itself within my findings. That is that more education was not associated with higher trust scores. In an ideal scenario, more education should lead to more trust in public institutions and less vaccine hesitancy. I'm not 100% sure why I got this finding, but I kind of have a guess. I think my data analysis might have negatively impacted. It might have been negatively impacted when I used the transformed vaccine hesitancy score data a lot. Again, I'm not really sure why this was going on. But on that note, let's get to the strengths and limitations of the study. So online surveys are easy to use because you can cast a wide net with very little effort, but they have issues with data integrity. Since they're anonymous, we had to take responses at face value. I had to essentially base my analyses and conclusions on the goodwill of the participants, but I had no way to verify this. There were hints of inaccurate responses, reported in income and age. So I decided that if a participant had at least one response that was an extreme outlier, which is plus or minus 3 standard deviations from the mean, I just completely took out all of their responses. This is why only 62 participants were included in the final data analyses, even though 65 met the inclusion criteria. Also, the survey was not as well distributed as I originally thought. I started off this project with the intention to post on 25 Muslim-oriented Facebook groups, but it was only shared in 10. This happened for a few reasons. Many Muslim-oriented Facebook groups were private and did not allow posts from non-members. Second, some groups deleted my marketing script and the link to my survey because they thought it was spam. Third, group administrators often didn't respond to my request to post the link to the survey and my advertising script. And lastly, most of the Facebook groups that I did get to advertise to and market my survey were dominated by South Asian and Sunni Muslims. And also, I have to show my own, admit to my own complicity in why my results came out the way they did. I am a South Asian Muslim woman, and the majority of my followers and friends on social media and in my public and personal life are South Asian, Sunni, and health professionals. I also shared my survey through KCU's email system, which is why there's an overrepresentation of educated individuals. We have access to health information sources and primary care. This definitely impacted my survey. For example, 96.8% of my sample received at least one dose of the COVID-19 vaccine, which is more than the 92.1% of all American adults who received at least one dose. There's a risk for recall bias and incorrect recollections. But I will say that there are a couple of strengths. I was able to, skew my linear variables with transforming my data. I was able to use my multiple regression analyses to get rid of the confounding variables of my t-tests. And lastly, I used pilot testing in the beginning stages of my of designing this survey to help eliminate any mishaps in the actual deployment of this survey. And so overall, I kind of want to go over what I would want to do differently to repeat the study. I would also like y'all's feedback on how I can modify the next study's design. I personally would like to recruit in person and online. A good way to do this is by approaching parishioners at various mosques of different religious Muslim sect affiliation in metropolitan and suburban areas during or after a busy religious event, such as Ramadan, like during the dusk prayers when we break our fast, or the biennial Eid prayers. These are the most popular Islamic events and are attended by casual and non-practicing Muslims, as well as very religious Muslims. So you can get a variety of religious beliefs reflected within the survey sample and get a diversity of responses. So overall, when addressing vaccine hesitancy sentiments, it's important to have clear goals, objectives, and metrics for determining how people's views impact how they view vaccines. Unfortunately, as with most behavioral health research, it's sometimes difficult to figure out the strength of a treatment or a program on behaviors. So public health scientists have to approach the study of vaccine hesitancy cautiously. Even so, I think one thing that we can say from, I guess, a physician, healthcare, clinical oriented perspective is to have compassion and empathy in how people engage with thought leaders, with other people who have influence over them on healthcare choices, including vaccines. Healthcare is a deeply personal choice, and it's reflected in how in people's backgrounds and their personal history and beliefs. And I can, like, even personally from talking to patients, it's easy to feel frustrated, annoyed, and even kind of disgusted at people when they talk about why, they are hesitant towards vaccines. But I think it's important to keep in mind that there's a variety of socioeconomic, sociopolitical reasons for doing things against someone's best interests. And so in all, it's important to have a sense of optimism and be proactive when developing someone's trust in vaccines. So thank you so much for taking the time for listening to my presentation. I'm sorry I went over time and was kind of late to come in today, but I'm now opening up the floor to any questions if we have any time, Dr. Staudinger.
You bet. Student Dr. Ali, that was a brilliant presentation. I love the obvious passion you're bringing to the topic. I have a quick question. Is this published?
Uh, Not yet. I really wish I had time in between my rotation schedule and studying to do more research and be more research minded, but unfortunately, no. I would really like to get this published. However, I when I did go to the APHA's like annual conference this past November, I got schooled by a number of public health scientists who are much smarter than me, kind on how to approach this. And I was advised to not publish it just yet and
Yeah.
maybe wait until I do my follow-up study. But I don't know, like with boards rapidly coming up, I just don't know when that will be.
Well, I can
Um,
completely relate to that disposition, but I would agree with those sentiments. In other words, yeah, extend the study. And I think in particular, one thing that you mentioned that would be interesting to flesh out a little better was
mhm,
different sects of Muslim Americans, Sunni, Shia, and other, to figure out if there's a correlation at all there. So as I read your data, there was mostly Sunnis that were responding to this, true, and just a few
mhm.
Shias. Yes.
Oh yeah, yeah.
So maybe just try to get more diversity in that subsect and larger numbers for sure. And I'll one other comment I'll make to you is
Mhm.
statistics give me personally hives, and to say the word statistical significance is always a challenge for me too.
Yes,
So
yes.
great
I
job.
fumbled quite a bit.
Great job. I see we have a number of hands up. Dr. Wolf, go ahead.
Yeah, thanks. I enjoyed your presentation. I had a quick question related to
Mhm,
your finding that younger people, or the impact of education, things along those lines. Because it seems to me that there's a tendency for people who are educated to want to take their health care into their own hands, and there's a tendency for them to reinforce each other's beliefs, however erroneously derived they might be. I mean, I did a alternative medicine thing for the skeptical care
ah,
provider many years
mhm,
ago that I coordinated, and that seemed to be a recurring trend that people would get their ideas based on peers and friends, and feel that they were employing their smarts appropriately, not realizing, I like friends will go, well, Fauci flip flops or whatever. I go, well, Fauci gave you the best information he had based
mhm.
on what was available at that time. And a real scientist changes their minds as 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 new information comes available. You've got to always interpret things to the best of your ability. And so I guess I was just, my big thing was that
Mhm.
educated people, I mean, I've seen many people who are smart do really dumb things. And it's because, or I'll try to shut up here, but like the Jenny McCarthy effect, or
Yes,
things like
yes.
that, where people go out there and there's influencers, and well, this person,
Mhm.
so Aaron Rodgers, well, he's got to know what he's talking about. Jimmy Kimmel's surely a pedophile because Aaron Rodgers said so. Things along those lines that I think are
Mhm.
just pervasive in our society.
Dr. Wolf, I am so happy you mentioned complementary and alternative medicine because I literally would not even be interested in the topic of vaccine hesitancy or even in like public health at all in the way that I do now if it wasn't for one of my professors getting me started on a complementary and alternative medicine like research project while I was in undergrad. And so, yeah, I definitely agree with you that there are contradictory findings in terms of education level and how people are vaccine hesitant or vaccine accepting, because you see it on both ends of the spectrum. A lot of education and little education contributes to vaccine hesitancy, as I have found throughout my literature review and just from basic like looking at people going on social media as a normal person scrolling through like everybody else. I see these trends across the board, people who don't know what they're talking about and people who kind of they know what I mean, they're educated and they know, but they are taking all of the information way too much in their head. And that's another reason why, like, whenever I like to discuss vaccine hesitancy with just other people who are not public health scientists, I like to sort of get out of the weeds in it, because it's really easy to just look at these numbers and be like, okay, well, such and such demographic tells me that such and such person is going to accept vaccines, so I don't have to worry about it. I don't need to counsel them on it when they're like coming in for their annual visit, whatever. And so I really think that it's important to engage with the patient and just talk to them. Like when I was in my peds rotation, we had a number of parents come in who, they mean well, they were educated, good, on the upper level of the socioeconomic, you know, socioeconomic factors, like on the good side of all of those things. But they had questions, they had doubts, and they were like, okay, well, I read this and I read that. But I'm so glad that my attendings were there to show me that, like, okay, well, this is how you engage with them. And that's another reason why I absolutely adore my attendings at my site, because they take the time to talk to people and to engage with them. Whether someone doesn't have a lot of education or whether they have a lot of education, engaging with vaccine hesitancy, I think often it really just comes from talking to people and literally just being like, okay, I understand why you feel that way. Well, let me tell you why that's not right. And of course, you're always going to get the one or two people, the outliers who don't accept anything you say, no matter how much information you throw at them, no matter how much you educate them about statistics, about how research is done. But you can't really, you're not going to change their minds. What my research likes to focus on, and what I really want to do in the future as a healthcare provider, is to really take up for those 99% of people who are hesitant, not really sure, but they just need that guidance and that reassurance that, like, I'm going to be there for them, and me telling them to get this vaccine is not me sucking up to the pharmaceutical companies and sucking up to some rep. It's literally because I want them to be alive. So yeah, thank you so much, Dr. Wolf.
Okay, we're going to go to Dr. Ponce now. Go ahead.
Thank you very much, Dr. Steininger. Miss Ali, great presentation. This is a subject that is very, in my opinion, is very delicate, and it's very sensitive for everything that's going on in the world right now.
Mm-hmm.
There is a lot of division, and as your study brilliantly told us, it's not something that has to do so much about, there's too many variables here.
Mm-hmm.
So I have to say first, congratulations, bravo. I loved your presentation.
Thank you.
It was very telling. I have my own ideas, but I think that you did an amazing research, and it was very clear, very direct, and also very sensitive of you to share it the way you did. That being said, I would like to ask you, and this is a very simple question, two actually. One, what was the size of your total sample? How many people actually you were able to apply the survey to?
So total number of responses that I got, I believe it was 75, and then 65 met the inclusion criteria. And then 3 of those responses had really wonky responses, because I looked at each and every person's like responses as they were coming in on Qualtrics. And so 3 of them had really strange reporting patterns. And so that's why I made that distinction of, if a certain number or a certain value was more than 3 standard deviations from the mean, I completely took out that survey, like completely. And so that's why 3 were taken out. And so 62 people made up my final survey.
Perfect. And my other question, and this is a personal question, feel free to to answer to the extent you want,
Okay.
but it's just mere curiosity. Do you personally think that every vaccine that is offered to the public is safe?
Okay, so all of the vaccines that are publicly available to Americans, to American patients, I think of it as that. Um, these are what I'm talking about. So in the short amount of time that I've been in all of my rotations and I've had the opportunity to really dive deep into vaccine safety, and to see the long-term, or not really long-term, it's only been a couple of months, short-term consequences of what happens to people on vaccines, I have found that yes, there are certain side effects, but I have even asked all of my attendings, I'm like, how often have you seen Guillain-Barré? How often have you seen a negative immunologic reaction to a vaccine? How many times has a person with some sort of immunodeficiency accidentally received a vaccine? Like, and these are people like not to be ageist, but they're old. Like they have a significant amount of experience under their belt. They know what, and I trust them to know what they're talking about. From all of them, they could not tell me a single case of any of their patients in the decades that they've been practicing in which they've seen an adverse reaction that was so bad that someone either died or had to be hospitalized, like significantly across multiple days. And so I think that yes, there are adverse consequences, but we're talking about like when I think about it in numbers, like 0.0000000, like 1% of people, like all people, all cases of people who get vaccines on a daily basis who are showing negative signs and symptoms. Obviously there are those like exceptions, like there are stories that I hear of vaccines getting contaminated, of like excuse me, of healthcare providers giving contaminated vaccines, and like stuff that hasn't been refrigerated properly. But I feel like, again, this is like, it kind of goes back to the ethics of medicine. Like, if you are an ethical healthcare provider, obviously you're not going to get vaccines that have, that you're concerned about, that you're worried about. Like, when, again, going back to pediatrics, because vaccines were such a big part of my pediatrics rotation, when my attending, like at their clinic, when one of their vaccine fridges broke down literally for like 2 hours, they threw away hundreds of vaccines. They had to reschedule every single baby and every single child who needed a vaccine for like the next week, simply because they did not want to risk it, and they didn't, and it was only like a few hours. What could possibly go wrong? But they didn't want to risk it. And so for those outlier, like exception cases, I really feel like that kind of goes back to healthcare ethics. Like it goes back to like, okay, you're not going to give something to someone if you're not sure. You're going to be, in the full, in your right mind when you're going into a surgery and scrubbing in. So stuff like that. But in terms of like actual allergic reactions that happen and actual vaccine reactions that happen from a healthcare point of view, like hypersensitivity reactions, that is like so rare. But again, it's medicine, so there's always an exception somewhere.
Perfect. Thank you so much. Again, congratulations. I almost said it in Spanish. Congratulations for a great presentation, Miss Ali. And what can I say? Great researching job.
Thank you. Thank you.
Here's a brief comment. You have a PhD in biochemistry and molecular biology, and I've got 5 COVID vaccines on my body. But when my first child was born, they wanted to give him 14 vaccinations on day 1. And I thought that was a bit much. So I had them spread out over a period of time. So I don't know how that fits with your data, but
technically by the very, technically that's vaccine hesitancy, because it's, delaying. But I can see why you would be kind of concerned, because it's a baby, their immune system isn't developed yet. And so I've heard varying arguments, but I don't know, like I've asked my pediatrics like attendings about this, and I was like, okay, what do you think about that? And they're like, okay, well, they've done research on this. This has been studied. Even though pediatrics research is ludicrously underfunded, this is the one thing they really like to focus on and the one thing they really pay attention to. And so there have been little tweaks over the years, but I don't think the vaccine schedule has changed much. I think
Right.
in the past 10, I mean, since I was a child, and I'm
Right.
like about to hit 30. So like, like I don't notice like any big changes. But I can't understand why it might be kind of it can be kind of distressing even to see a
Yeah.
baby with lots of needles.
Yeah, and it was my first child. And
Mhm.
by the way, he's bouncing and healthy now at age, God, I guess he's 15 already. And I
Mhm.
think one of the best things I did for him was raise him on a farm. And so he
Mhm.
was he was rolling in all kinds of chicken and cow and pig
Mhm.
excrement from a very early age. I'm fairly certain he had a spoon involved at one point. I'm not sure. At any rate, immunity is an interesting thing. It's a hot topic that you've touched on.
Mhm.
Based on all the questions you're getting, I would, if I were you, endeavor to continue this study and do publish it at some point. I think it'd be very interesting
Mhm.
and probably well received by readership in this world and times that we're living
Mhm.
through. So if there are no other comments, we're well over. But student Dr. Ali, thank you again for participating. During this session, I had, believe it or not, 5 emails of folks who want to sign up. This thing is getting really, really popular, but I also had 1 cancellation, and that's for next week. So we'll reconvene 2 weeks from now. Let me quickly just drop this link in the chat for those who don't know where this site is. And I think, Dr. Ponce, I'm going to need to enroll you in this site. If you click on it, it likely won't let you in because this is a Canvas site. And are you officially signed, sealed, and delivered? You're a real
That's something
citizen.
I think that's part of what I need to do in my next presentation, doctor. So I am gonna leave that in a big maybe.
Yeah, that's fine.
But I have definitely I definitely want to enroll in this. But
Yeah.
I am actually I might even contact you later
Okay,
because now I am not really sure.
no worries. And we'll get this done moving forward. Student Dr. Ali, thank you again. Appreciate everybody showing up, and I'll see you
Oh
folks.
yeah, no, I am going to be in this in a few. It's part of my presentation. I'm going to be enrolled today.
Okay, good. All right
Thank
then.
you.
Thank you, everyone. Thank you, Dr. Staudinger.
Bye now. Be good.